Focus today on healthcare-associated infections, or HAIs. Some people might know them by the older term, nosocomial infections. The three overlapping requirements, the perfect storm, are: first, the presence of microorganisms. The agents of infection, they have to be in the hospital environment.
Right, the germs.
Second, you need an immunocompromised or vulnerable patient population. These are the people whose defenses are already down, either from their illness or the treatments they're getting. And third, you need the transmission of pathogens.
If you manage to remove any one of those three elements, if you rigorously sanitize the environment, or you totally isolate the transmission path, or if the patient wasn't vulnerable, the risk just collapses. It's the convergence of all three that creates the problem. It's not just germs, they are tenacious life forms. The bacteria, for instance, they often have these incredible mechanisms to stick to plastic surfaces like catheters.
Biofilms.
Right, they form these protective layers called biofilms, which makes them exponentially harder to kill than just free-floating cells.
That's a crucial point. Biofilms are like the microbe's defensive armor. It allows them to cling to devices, to surfaces, and just patiently wait for the patient's immune system to fail, or for a procedure to create an entry point. The difficulty is that the hospital environment is simultaneously the place we house the sickest people who lack natural defenses, and the place where these resistant armored agents are most concentrated. First, CLABSI. That's central line-associated bloodstream infections.
And these are exceptionally dangerous.
Extremely. A central line gives us direct high-flow access to the large central veins for essential treatments. But if it gets contaminated, it also offers a direct, rapid route for bacteria to flood the patient's entire circulatory system. Next, we have CAUTI. That's Catheter-Associated Urinary Tract Infection.
Then we track VAE, or Ventilator-Associated Events. This is an infection or complication related to being on a breathing tube, an endotracheal tube, and mechanical ventilation. The patient is often unconscious, paralyzed, or otherwise unable to protect their own airway, making them extremely vulnerable to microbes entering the lungs.
And finally, SSI, the surgical site infection. This is an infection that occurs in the part of the body where the surgery actually happened, and SSI is a devastating setback for a patient. It can mean repeated surgeries, it dramatically increases pain and recovery time, and it drives up healthcare costs exponentially.
Aureus Methicillin-Resistant Staphylococcus aureus. MRSA. This is the definition of a superbug.
It is. The first major risk factor is, as we've mentioned, the use of indwelling medical devices. We insert central lines, urinary catheters, endotracheal tubes. Why does this create risk? Because these devices literally bypass the body's natural defensive barriers, the intact skin, the mucous membranes.
The fortress walls.
Exactly. These natural defenses are incredibly effective filters. When we insert a catheter, we're creating a direct pathway for bacteria, and that pathway is frequently a breeding ground because of the plastic surface promoting those biofilms we talked about.
Any surgical procedure itself opens the body to risk. That's why SSI prevention is so critical.
An incision is a breach of the fortress walls. The patient is temporarily vulnerable to contamination from the air, the instruments, even their own skin flora. And the longer the surgery, the higher the risk of exposure and infection.
Third, and this is maybe the greatest long-term concern, is antibiotic misuse.
Exactly. By killing off all the susceptible bacteria, we remove their competition. The resistant 1% then have a field day unlimited resources and space to multiply. This is called selective pressure. We are inadvertently selecting for the toughest bacteria every single time we use an antibiotic unnecessarily or fail to complete a course.
Exogenous.
This is caused by organisms that are already present as part of the normal flora of the patient. The patient's own body is the source. We all have trillions of bacteria on our skin, in our gut, in our respiratory tract that are normally harmless. But when a procedure happens, say an incision or a catheter is inserted, these commensal organisms are given an unauthorized path past the protective barriers.
So if a common skin bacteria like Staphylococcus epidermidis is carried deep into the bloodstream when a central line is placed, that's endogenous. The body is effectively infecting itself under the right invasive conditions.
Second source is exogenous, or indirect infection. This is the cross-infection risk. The organisms are acquired from outside the patient, from hospital personnel, contaminated medical devices, or the hospital environment itself.
Most common is contact hand-borne transmission. This is the workhorse of HAI spread, and it breaks down into two critical forms.
Right. Direct contact means physical transfer during patient care. This is the physical examination, direct patient contact, or staff clothing brushing against a contaminated surface, and then the patient's surgical site. And critically, it includes droplet contact followed by auto-inoculation.
Look at that.
That means a patient or a staff member touches a contaminated droplet from a cough or sneeze and then touches their own mouth, nose, or eyes, introducing the pathogen into their own system.
And then there's indirect contact, which is where those inanimate objects we just talked about truly earn their role as vectors. This involves contaminated articles, the bedpans, the jugs, the needles, the dressings, and critically contaminated gloves. Second mode is airborne transmission, which is the aerial route.
Think of diseases like tuberculosis, measles, or varicella, chickenpox. These particles can infect someone who enters the room long after the infected person has left.
We have the final three modes, which are less frequent in modern Western hospital HAI reports, but still critical to recognize. The oral route ingesting contaminated food or water, the parenteral route transmission through breaches of the skin, like injections, blood exposure, or sharp injuries,
which emphasizes safe handling protocols. And finally, the vector-borne route, which is through pests like mosquitoes, flies, or rats. First, absolute adherence to hand hygiene. Second, the use of sterile personal protective equipment, PPE, maximal barrier precautions. This means a sterile gown, gloves, mask, and a full-body sterile drape over the patient.
Third, and this is where clinical judgment comes in, site selection is paramount.
That the subclavian vein is preferred, and there should be an avoidance of the femoral vein due to a significantly higher infection risk. The femoral area in the groin is anatomically close to potential contamination, making it extremely difficult to keep clean, especially in obese patients.
Okay, fourth, the crucial step of skin prep. This requires the use of chlorhexidine, which is a powerful antiseptic, but it's not enough to just apply it. The instruction is very specific, ensuring the skin is completely dry afterward. And fifth, the need for a semi-permeable dressing to cover the site. And the sixth step is accountability, documentation, recording the date and time of insertion.
Documenting the insertion date forces the clinical teams to constantly ask, is this line still needed? The longer it stays in, the higher the CLABSI risk.
Next, let's look at the urinary catheter bundle, designed to prevent CAUTI.
Addressing the fact that CAUTI is the most common HAI. The first and most important element is restraint. The catheter must be inserted only when an appropriate indication is present. The procedure requires sterile items and a strict non-touch technique during insertion. The insertion itself introduces the catheter into the sterile bladder.
Once it's in, maintaining the integrity of the system becomes everything.
That's the third point. Maintaining a closed drainage system is key. This is the main defense against an ascending infection. If the system is open, say, to collect the urine sample from the bag, or if the bag is allowed to touch the floor, bacteria from the outside world can climb up the tube and into the bladder.
The final steps seem to involve mechanical stability.
Yes, using the appropriate size catheter minimizes trauma, and ensuring it's secured after placement prevents movement or tension that could cause irritation to the urethra or allow microbial migration.
Let's cover the ventilator care bundle, designed to prevent VAEs, the serious risk of pneumonia associated with breathing tube.
First is positioning, maintaining the elevation of the head of the bed to 30-45 degrees.
Which is a simple measure that uses gravity.
Exactly, to significantly reduce the risk of stomach contents or oral secretions being accidentally aspirated into the lungs.
Second, rigorous oral hygiene.
This is a daily requirement using a chlorhexidine 2% solution. The mouth is a massive reservoir for bacteria. If we significantly reduce the bacterial load in the oral cavity, any secretions that are aspirated will contain far fewer harmful organisms, lowering the risk of pneumonia.
The next two steps involve general critical care assessment.
Precisely. Clinicians must daily assess the need for peptic ulcer disease, PUD, prophylaxis. Critically ill, ventilated patients are at high risk for stress ulcers. If prophylaxis is needed, only sucralfate should be used. And similarly, deep vein thrombosis, DVT prophylaxis, must be provided if needed, as immobility significantly heightens the risk of dangerous blood clots.
And the final core philosophy of device management comes back into play here.
It does. There must be a daily assessment of the patient's readiness for the removal of mechanical ventilation, MV. If the patient is clinically able to breathe on their own, removing the invasive device is the fastest way to eliminate the VAE risk entirely.
Finally, we turn to the prevention of surgical site infections, SSI.
The SSI strategy is the most complex because it spans 3 phases: preoperative, intraoperative, and postoperative. Let's detail the preoperative measures. Preparation starts days before the incision. This includes preoperative bathing, often with an antiseptic wash, to reduce the overall microbial load on the skin.
And specifically targeting the high-risk carriers.
Yes. For patients identified as MRSA nasal carriers, there must be decolonization using euperose ointment applied to the nostrils. Why? Because even the best skin prep in the operating room is useless if the pathogen is already on the patient's skin, ready to migrate into the incision. Decolonization reduces that endogenous risk substantially.
What about hair removal? That seems like a basic step.
It does, but hair removal is strongly discouraged unless absolutely necessary. Shaving with a razor causes microscopic abrasions that pathogens love to colonize. If removal is required, it should be done only with a clipper, which minimizes skin trauma. And finally, preoperative oral antibiotics combined with mechanical bowel preparation is required for elective colorectal surgery to target the extremely high microbial load in the gut before a procedure risks breaching the intestinal wall.
Moving into the intraoperative measures.
Surgical antimicrobial prophylaxis, SAP. A preventative dose of antibiotics must be provided for all surgeries except clean surgeries. Antibiotic has to be timed so that the concentration of the drug in the patient's tissue is at its peak effective level right at the moment the incision is made. Too early, and the concentration drops. Meticulous surgical hand disinfection by the operative team is mandatory. Then, surgical site preparation on the patient with alcohol-based antiseptic solutions based on CHG or chlorhexidine. CHG is preferred because it not only kills microbes on contact, but leaves a residual effect on the skin, providing protection throughout the procedure. The surgical team has to maintain optimal perioperative oxygenation, temperature, and blood glucose level. Hypothermia, low oxygen saturation, or high blood sugar are all known to suppress the immune system and impair wound healing.
The SSI strategy concludes with post-operative measures.
These are simpler but critical for maintaining that sterile bubble created in the operating room throughout recovery. This involves daily wound dressing changes to protect the vulnerable site from external contamination, and the appropriate use of postoperative antibiotics only when specifically indicated by the clinical picture, avoiding unnecessary antibiotic use, which, as we discussed, just feeds the resistance problem.